social media's #1 platform for spine health education and surgery. Join with us now.
Welcome, everybody. We are into another great installation for spine surgery. We are going to be talking about something very important that we see so often in the group, that bone quality, bone density issues are results to failure of back surgery. So I have the great Dr. Alexandre Rasouli with me here today. Good morning, Dr. Rasouli.
Good morning, Jamie.
And, the folks are really excited about doing this, learning about this. So as I mentioned, 41% of failures from back surgery is from poor bone density. That's a huge number. And so many times we see images on our group, and a lot of people think it's a device failure, but it's always bone density failure. And do you think, as a whole, Dr. Rasouli, spine surgeons kind of look at that as much as they should? I know you do, but I wonder about your colleagues sometimes.
Yeah, no, first off, I want to give a warm welcome to the amazing members of your group who keep the discussions going and allow us to be able to have a really good dialogue about all the great things that can be done with spine to restore the quality of life. I think it's really unprecedented what you've done and what the members of your group have done. I agree that bone density is an overlooked issue. It's an overlooked factor in deciding who's appropriately qualified for this replacement or spine surgery in general. And I'm not talking about the people with obvious bone density issues with osteoporosis, those that register as having osteoporosis on DEXA scans and things like that. I'm talking about young people who are in the prime of their life, come to have a disc replacement, and we discover that they have significant issues with their bone density. And that's what's overlooked. Historically, those people undergo artificial disc replacement, especially in the lumbar spine, only to find that their constructs have failed. And if you have enough of those as a surgeon, you start to look around and try to figure out what's going on. So what's going on is two things. Number one, a so far unknown reasons, a lot of people are suffering from bone density issues earlier in life, and we don't know why. And the second issue is that the DEXA scans, which is the traditional tool we use to identify people with bone density issues, often fail to identify the people that are suffering from those borderline bone density problems between osteoporosis and a middle ground called osteopenia. Oftentimes, the DEXA scan overestimates the bone density. So what we've developed in the last few years is a reliance on the CT scan. That's the imaging that we would get anyway for these surgeries, but by measuring, using specialized measuring techniques, the pixel density of the bones that are going to undergo disc replacement and establishing thresholds of what appropriate bone density is, we can identify those who would do well with a disc replacement and those who would probably undergo failures with the disc replacement in a way that the DEXA scan has not been able to identify, and in a way that we have never been able to identify before. So it's really an unprecedented measure that we can use to be able to react appropriately. So let's say a patient has plans to undergo a disc replacement. We order a CT, we measure their bone density using the pixel density on the CT scan. And if they're above a certain number, the number is 160 units. We can discuss that later. They're a good candidate for artificial disc replacement. If they're below 160, between 130 and 160, we use a little bit of cement above and below the disc replacement. And since we've started doing this, our failure rates from bone density issues has pretty much gone down to zero. If they're anywhere below 130 of this units of bone density on a CT scan, we start to question whether they're good candidates for disc replacement at all. Some end up doing well with some cement. Some have to wait and go on the medications that we can describe. But that's the situation, is a new way of measuring bone density that's super sensitive and able to predict who will do well and who won't. The use of cement, bone cement technology to be able to shore up the bone to make it stronger for disc replacement. And this trend that we can't quite identify the reasons for, where younger people are suffering from bone density issues.
Yeah, there's some members in my group that over the past 7-8 years that have had bone density issues, and 31-year-old male from England, and it's just, and the list just populates and populates. Fortunately, some of these people catch it before they get surgery, which is good. And that's why these videos are so important, is to have the type of information that you have. But let's give a little scenario. Say I'm 35 and I'm borderline osteoporotic, right there in the middle.
Yeah.
What would you suggest this patient to do if they can hold off?
If they've been identified by a CT scan as being in that gray zone where we have to kind of step back and reassess things, and where we've determined that even with some cement augmentation around the bones is still not a good candidate, they can go on medications, of which there are many now, to fortify their bones. Historically, for osteoporosis, medications relied on one of the two factors in bone density maintenance. The first is a process driven by a cell called osteoclasts. Osteoclasts break down bone, not for the sake of just breaking them down, but for the sake of remodeling bone. Bone has to be remodeled and curated and all that. And the second factor is controlled by a cell called osteoblasts, which control bone growth. So they build bone. And so there's a battle between the cells that break down bone and the cells that create bone. And if you have more of the first kind, the breakdown by the osteoclasts, you end up having bone density issues. So medications will either target the breakdown of bone or the creation of bone. And historically, the medications that a lot of people know about, like Boniva, for example, they prevent the breakdown of bone or further breakdown of bone, but they don't really build bone. And that was one of the problems with these medications. So the newer medications will actually build bone because they work on the osteoblasts, which are trying to put down bone and form it. So a slew of amazing medications in the last several years allow us to really activate bone growth rather than preventing further bone loss. And it's those medications that would benefit the younger people with bone density issues. They can go on it for 6 months, a year, maybe a little longer, and really maximize their chances of having a bone density that lends itself to good results with the disc replacement.
And with your patient population, do you see many side effects from getting on these drugs?
Well, we don't see many side effects. There aren't that many side effects, and if there are, we see them uncommonly, and they usually relate to leg swelling or the patient just not feeling very well. That could really be a response to anything, but if that happens, be taken off those medications.
And what are a few of the ones that you use that seem to work well?
Well, the first one of its kind on the market was a medication called Forteo. Forteo allowed modulation of the body's own bone building or osteoblast activity through the parathyroid hormone. Parathyroid hormone builds bone. So this Forteo mimics that process and allows the cells to start to create bone. A second very closely related medication is called Tinlos, which basically does the same thing. And then the newer medication called Evenity controls both cells. It prevents the breakdown of bone and promotes the building of bone. So it's the best of both processes combined in one medication. It's true, and I'm sure there are more in the pipeline.
Yeah, it's amazing because there was one I shared with you a little bit ago. I can't remember the name, but it seems like there's a growing population of need because we see it. We know seniors that fall and break bones and different things. And my mother, for example, 77, and she's on one, and she's fantastic from it, and no side effects. So I think it's so important. So I'm an inpatient patient. And you tell me, hey, we got to wait it out a little bit. How long does it take these drugs to kind of work?
At least 6 months, maybe a little longer.
Okay.
And the patients who are really in a rush to get their surgery their impatience should be tempered by the fact that if they undergo a disc replacement and it fails, there's really no good salvage for that. And so they need to understand what's at risk. A disc replacement is amazing surgery, provided that there are certain factors that are optimized prior to the surgery.
And do you do a blood panel as well? Say you're seeing a patient, 31-year-old male, let's go back to him again, and you're seeing some poor bone quality. Will you run up a blood test just to kind of check the hormones to see if they're off or not?
I think that's a great question. If there's somebody young that comes to our office with bone density issues already in life, the first thing we do is we refer them to either an endocrinologist or and internists so that they can work up the reasons why the patient's having bone density issues. And as I said, we're seeing an alarming trend of younger people with these issues. And as yet, we don't really have good answers. But yes, we don't order those tests ourselves. We kind of refer them to doctors that are more qualified to run those tests. They know what to look for. Sometimes they uncover a process that has to be rectified before they have surgery.
That's what's great about your practice, Dr. Rasouli. You cross every T, you dot every I. You make sure that everything is complete to have that success, and we see it. We see with so many people that come to you and they leave and they're doing fantastic. And, whether it took them 6 months or a year to kind of get to that spot, it's definitely evident. And I hope that a lot more surgeons, and I know most of them don't, at least a lot of the ones I know, do not do this type of practice. And it's so essential, because if you have something broken on one side, trying to fix it with something else isn't going to help unless you're that perfect patient right now. So important. Is there anything else you wanted to cover?
Well, no, I appreciate the kind words. We certainly enjoy what we do, and we certainly love helping people get better. I think it's really important for people to know that good surgery is a culmination of a lot of factors and a lot of people. And one of the factors we've been seeing more and more is how robust the patient's bone density is, and because you need strong bones to support the devices that we put in. And no matter how elegant the device is, if the bone can't support it, it'll fail. And sometimes even in the best circumstances, everything's been optimized, they still fail, but they do so rarely. Fantastic knowledge.
We thank you so much, Dr. Rasouli, for taking time this morning and doing us for everybody, just to kind of keep them up and going and having positive results, and the success is completely there. And I know we're very grateful to you.
Well, it's our pleasure, Jamie. We're grateful and privileged to do it.